Today we will be going over anatomy and biomechanics of the elbow. On the agenda today is the clinical relevance, the osseous anatomy, soft tissue anatomy, neurovascular anatomy, and the biomechanics. Starting with the clinical relevance, the elbow is a trochoganglymoid joint, meaning it has 2 degrees of freedom. It's capable of both flexion and extension, as well as supination and pronation, and making it play a key role in the positioning of the hand in space. This makes the hand and elbow both essential for independent living and activities such as eating, dressing, and toileting. There are 3 articulations to the elbow joint: the humeral ulnar joint, the radiocapitellar joint, and the proximal radial ulnar joint. Bony landmarks of the humerus include the lateral condyle, which is the origin site of the extensor mass and the LCL, the medial condyle, which is the origin site of the flexor mass and the MCL, the cubital tunnel, which contains the ulnar nerve, as well as the olecranon fossa and the coronoid fossa, not pictured here. On the articular surface, the capitellum articulates with the head of the radius, and the trochlea articulates with the olecranon. In the radius, we have the radial tuberosity, which is the site of the biceps insertion. On the ulna, the olecranon, which articulates with the trochlea, the coronoid process, which provides anterior stability, and pictured here now is the supinator crest, which is the insertion point for the LUCL. The ulnar tuberosity is the insertion site for brachialis. The greater sigmoid notch accommodates the olecranon and the coronoid, and the lesser sigmoid notch articulates with the radial head. The elbow is encased by the joint capsule, which forms a synovial joint. The capsule is here pictured roughly in gray. The anterior capsule arises proximally above the radial and coronoid fossa of the humerus and attaches to the anterior surface of the coronoid medially and the annular ligament laterally. Posteriorly, it attaches above the olecranon fossa and distally around the medial and lateral margins of the sigmoid notch. There are 2 ligamentous complexes that contribute to the static stability of the elbow joint. The medial collateral ligament complex, or the MCL, is comprised of anterior and posterior bundles, as well as the transverse ligament. The anterior bundle originates from the anterior-inferior aspect of the medial condyle and inserts onto the sublime tubercle of the ulna. Posterior bundle originates behind the anterior bundle and inserts along the mid-portion of the greater sigmoid notch. The anterior band of the anterior bundle is the primary constraint to valgus and internal rotary forces. The posterior band is secondary, followed by the posterior bundle. The lateral collateral ligament complex comprises the radial collateral ligament, the annular ligament, the lateral ulnar collateral ligament, and the accessory lateral collateral ligament. The RCL inserts along the annular ligament, and the LUCL inserts onto the tubercle of the supinator crest of the ulna, which was pictured on the osseous anatomy slide. The LUCL is fundamental to the trochlear greater sigmoid notch congruity, and both ligaments resist various forces across the elbow. The annular ligament attaches to the anterior and posterior margins of the lesser sigmoid notch, maintaining the proximal radial ulnar joint. Next, we have the muscular anatomy. The muscles crossing the elbow joint act as dynamic stabilizers and protect the static constraints from the previous slide. There are 4 muscle groups around the elbow: the flexors, including biceps, brachialis, and brachioradialis; the extensors, including triceps and anconeus; the forearm flexor pronators, which originate from the medial epicondyle described previously and include pronator teres, flexor carpi radialis, palmaris longus, and flexor carpi ulnaris. And finally, we have the forearm extensors, originating from the lateral epicondyle, and include extensor carpi radialis longus, extensor carpi radialis brevis, extensor digitorum communis, and extensor carpi ulnaris. The resulting force created by these muscles is directed posteriorly, and the coronoid process acts as a buttress against posterior displacement of the elbow, therefore all contributing and playing an essential role in static and dynamic elbow stability. Moving on to neurovascular anatomy, The radial nerve approaches the elbow between the brachialis and the brachioradialis muscles in the anterior compartment of the arm. It passes under the extensor carpi radialis longus and brevis to pass anterior to the lateral epicondyle. It divides into the superficial radial nerve, or the SRN, and the posterior interosseous nerve, or the PIN, at the level of the radiocapitellar joint. The SRN continues under the cover of brachioradialis towards the wrist, while the PIN passes between the two heads of supinator into the extensor compartment of the forearm. The median nerve crosses the brachial artery to lie on its medial side between the biceps brachii and the brachialis muscles. The artery and nerve pass deep to the bicipital aponeurosis at the elbow and lie medial to the biceps brachii tendon and anterior to the brachialis muscle. The nerve then passes under the humeral head of pronator teres, then between the humeral ulnar and radial heads of the flexor digitorum superficialis muscle to enter the forearm. It gives off the anterior interosseous nerve about 5 to 8 centimeters distal to the lateral epicondyle. At the mid-arm level, the ulnar nerve passes between the medial intermuscular septum and the medial head of the triceps, then onwards into a sulcus behind the medial epicondyle of the humerus, then passes through the cubital tunnel and enters the anterior compartment of the forearm between the two heads of flexor carpi ulnaris to lie beneath the muscle belly of flexor carpi ulnaris. Not pictured here are also the medial and lateral cutaneous nerves of the forearm. The medial cutaneous nerves of the forearm provides cutaneous innervation to the medial aspect of the distal third of the arm, and the lateral cutaneous nerve is an extension of the musculocutaneous nerve. Moving on to the vascular anatomy, the elbow is supplied by the brachial, radial, and ulnar arteries and their recurrent branches. The brachial artery courses the medial arm between the median and ulnar nerves. After passing under the bicipital aponeurosis, it enters the antecubital fossa in the midline of the elbow, lying medial to the tendon of biceps brachii and lateral to the median nerve. At the level of the radial neck, it bifurcates into the radial and ulnar arteries. The arteries around the elbow contribute to 3 vascular arcades: the medial, the lateral, and the posterior arcades. Starting with the medial arcade, which is formed by the superior and inferior ulnar collateral branches from the brachial artery. They anastomose with the posterior ulnar recurrent branch of the ulnar artery around the medial epicondyle. The medial arcade supplies the medial epicondyle, the medial aspect of the trochlea, and the posterior medial olecranon. The lateral arcade is formed by the descending radial and middle collateral arteries, which originate from the profunda brachii, and they anastomose with the ascending interosseous recurrent and radial recurrent arteries on the posterior aspect of the lateral epicondyle. This arcade supplies the lateral epicondyle and the capitellum. The posterior arcade is formed in the olecranon fossa by anastomosis of the superior ulnar, radial, and middle collateral arteries proximally, as well as the interosseous recurrent artery distally. Moving on to biomechanics of the elbow. The elbow is primarily a hinge-type joint, allowing flexion and extension from 0 to about 140 or 150 degrees of flexion, and this is inhibited by the bulk of the biceps. Somebody with a larger biceps bulk may have less range of motion, whereas somebody like Sarup with a smaller bulk of the biceps would have greater range of motion. It is also limited by the impact of the coronoid against its fossa and likewise the radial head against its fossa. When the elbow is ranged from extension to flexion, there is approximately 4 degrees of varus valgus movement, and this is normal. The radius rotates around the ulna to create forearm rotation from approximately 75 degrees of pronation to 85 degrees of supination, and this is independent of elbow position. Angular deformity of the radius or ulna less than 10 degrees does not affect forearm rotation. Stability of the elbow joint is achieved through a combination of static and dynamic constraints. The three primary static stabilizers are the ulnar humeral joint, the anterior bundle of the MCL, and the LCL. When these are intact, the elbow is stable. The secondary stabilizers are the radiocapitellar joint and the joint capsule. Muscles that cross the elbow, described previously, act as dynamic stabilizer, and these include the anconeus, brachialis, biceps, triceps, as well as the common flexor pronator mass and the common extensors. The trochlear and greater sigmoid notches of the proximal ulna are highly congruent and to a degree constrained, thus providing inherent osseous stability. In flexion, the coronoid process locks into the coronoid fossa of the distal humerus, while in extension, the tip of the olecranon fits into the olecranon fossa, resulting in stability at the extremes of motion. The MCL complex consists of three components, of which the anterior bundle is the most important and restrains valgus and posterior medial instability forces. The anterior band of the anterior bundle is taut from 0 to 60 degrees, and the posterior band is taut from 90 to 120 degrees, providing resistance to valgus load throughout the arc of the elbow motion. The posterior bundle is a thickening of the capsule, while the transverse ligament does not contribute to joint stability. The ulnar component of the LCL complex originates along the surface of the lateral epicondyle and inserts into the supranutor crest, and is also a primary elbow stabilizer, restraining varus and posterior lateral rotary instability. The anconeus is thought to provide additional dynamic restraint, although its role is uncertain.